Okay. Sia, you want to go ahead and kick us off?
Sure. And I'm gonna say sorry in advance if there's a little bit of background noise. I'm at work, but I tried to find a quiet place, so I'm hoping this works. It says you disabled screen sharing.
Okay. Here we go. Now try.
Okay, there we go. Can you guys see this?
Yep.
Okay. So yeah, I will be doing the shoulder joint for you guys. So this is just a little surface level knowledge about the shoulder joint, and I'm sure most of you guys know this, but of course throughout the presentation I'll dig a little deeper into it. But for starters, this is the most freely movable joint within the body, and it is also a multi-axial synovial ball and socket joint. And this is one of only two of the ball and socket joints within the body. The other one is the hip bone, and we've discussed that in lab prior a little bit. And then this is also referred to as the glenohumeral joint, just because of the bones it connects to, which is the humerus, and then the glenoid bone, which is the socket part of the ball and socket joint. So as shown in this visual, the ball and socket joint of the shoulder are formed by the head of the humerus. So right here, the humerus head kind of serves as the ball part of the ball and socket joint. And then the glenoid cavity, which is right here, is the socket part where the bone, the humerus bone, sits into and attaches for the joint. And then because of the extreme mobility this joint allows us to do, there are all sorts of different motions and movements available. There are flexion, extension, internal and external rotation, as well as abduction and adduction as well. So lots of movements can be associated with this joint. And so these two pictures are a much more descriptive picture for you guys to see really what is all a part of the shoulder joint. And this shows the ligaments and the tendons and the muscles and the bones as well. So a lot going on in this joint really. So I'll start off with right here, and this is the glenoid labrum. And it sits within the glenoid cavity, and the cavity is right here, as you can see. And then this is just a little pocket of fibrocartilage. And because the cavity is such a shallow one, it really does little to help support the joint stability. However, this fibrocartilage helps to add just more of a glide. It's easier for the bones to glide across rather than rub and cause friction on. And then next we have the articular capsule, which this picture shows it a little bit down here, but over here I think this is a better picture of it, and this purple area right here is the articular capsule. And this is a super loose and very thin structure, and it completely surrounds the joint itself, hence the word capsule. It encapsulates the joint. And it helps to keep the bones separated from each other. So later on, I'll talk about a couple disorders that can occur if the bones begin to rub against each other. And so basically this capsule helps to keep those bones separated and prevent that from happening. And then this capsule extends from the margin of the glenoid cavity to the anatomical neck of the humerus. And then the articular capsule is then reinforced by the glenohumeral ligaments. So if you can see this, number 1 is the superior glenohumeral ligament, number 2 is the middle glenohumeral ligament, and then 3 is the inferior glenohumeral ligament. And each of these have different thicknesses associated with them to provide structure and support for different parts of the shoulder joint. And these ligaments are found on the anterior side of the capsule, and then the superior side of the capsule, which is up here, contains the coracohumeral ligament. And this ligament is right here, this little guy, and this helps support the weight of the upper limb, and then it also just strengthens the uppermost part of the articular capsule as well. So really focuses on up here. So some of the ligaments found within this joint can include the coracoacromial ligament, which is this one right here. And like it says in the name, it can attach the acromion to the coracoid process. And this basically just adds a protective covering for the upper portion of the humerus right here, so adds some covering there. And then we have the coracoclavicular ligament. I really struggle with saying that word, but it's these guys right here. And the coracoid process with the clavicle. And then these also play a role in supporting the shoulder joint as a whole as well. And then next we have the acromioclavicular joint. And this, like the name says, attaches the acromion to the clavicle. And it really just helps allow additional range of rotation and motion for this joint because, like I said earlier, there's a lot of mobility associated with this joint. So there's different parts that add to that mobility. Also found within this joint is the subacromial bursa, and that's this blue guy right here that extends along there. And this is a small fluid-filled sac that is situated between the acromion, so right here, and then the supraspinaceous muscle and tendon, as well as it extends down between the deltoid muscle and the greater tubercle head of the humerus. And this bursa's function is to facilitate the gliding of muscles or tendons over bony or ligamentous structures within the shoulder joint. There are also a few other bursas throughout the body, but for this particular presentation, I'm just focusing on this one, of course. And then another piece of the shoulder joint is the coracoid process, which I've talked a little bit about, but this also plays a really big part in the shoulder joint. And this is a small hook-like structure, as you guys can see here, and it's found on the superior border of the head of the scapula. And from there, it extends upwards and outwards. And this helps to stabilize the shoulder joint as well. And as I showed before, those ligaments right here and here, it plays a role in just support of the shoulder joint. And then we have the acromion, which is another pretty big process for the shoulder joint. And it's a bony process on the scapula, and then together with the coracoid process, it extends laterally over the shoulder joint. And this structure really helps protect the glenoid socket or the cavity, which this ball and socket is, the joint is. So it really helps provide a lot of protection there. So for innervation to the shoulder joint, all nerves supplying the shoulder joint originate from the brachial plexus. And as you guys can see in this visual, here's the brachial plexus right here. And the brachial plexus is a network of nerves that is formed by the lower four cervical and then the first two thoracic nerves. And then from there in the visual, you can see that it goes, originates up there by the neck and then spirals down through both the axial skeleton as well as the appendicular skeleton. And then innervation of the joint is a function of the suprascapular, lateral pectoral, and then auxiliary nerves. And I just thought this was a little interesting, but without the suprascapular nerve, abduction and adduction would not be possible. So I just thought that was kind of interesting. So a couple diseases and disorders I'll be talking about associated with this shoulder joint. The first one will be glenohumeral arthritis, and this is also referred to as glenohumeral degenerative joint disease or osteoarthritis of the shoulder as well. And this condition can occur when the articular cartilage that is found between the bones of the shoulder become damaged and they start to break down and deteriorate. And so then when this deterioration occurs, the bones are then exposed to each other, which causes a lot of rubbing and friction. And this friction then leads to the development of bony outgrowths or osteophytes, which is the direct result of this friction. And remember, when we break this word apart, osteo, of course, means bone, and then phytes means a growth, hence the word osteophytes. So they're just bony outgrowths that occur as a result of this friction. And so these osteophytes can really hinder the mobility and overall motion of our shoulder joint. And so it can directly impact our daily activity and movements. And so some symptoms for this particular disease can include a sharp pain due to the rubbing of the bones within the shoulder joint. And then as these osteophytes continue to develop and grow, a progressive increase in pain usually occurs. And then there's also discomfort and difficulty in movement, and a great decrease in range of shoulder motion is also usually a common symptom for this particular disease, as well as inflammation of and around the shoulder joint as well. as well. So lots of symptoms with this disease. And then there are multiple different forms of treatments for glenohumeral arthritis. There are both surgical procedures as well as non-surgical options as well. So I'll start with the surgical ones. The first one they can do is arthroscopy. And this is done for less severe cases of glenohumeral arthritis. And basically what they do during this procedure is just stick a small camera in an incision at the shoulder joint, and then they pretty much just assess the damage and see where they need to go from there, whether that be a shoulder reconstruction, which I'll talk about next, or they can go with some more non-surgical procedures as well and try those. And then next we have arthroplasty, which is done for more severe cases of this type of arthritis. And it is also known as shoulder replacement surgery. And so in this procedure, what they do is they go in and completely rebuild and replace the damaged parts of the shoulder with prosthetics to make it more functioning and have them mobile again. And then some non-surgical treatments with this disease can include viscosupplementation, which involves injecting hyaluronic acid into the joint to improve lubrication and cushioning, as well as cause a reduction in friction of the moving joints as well. And then also you can use corticosteroid prescriptions, which is a very common method of pain relief for many different types of injuries and diseases. And so not just the shoulder joint, of course. And so what these do is they help relieve pain temporarily, but don't really help with the cure overall. So they basically mask the pain for a couple weeks to a couple months. And then once that begins to subside from working, then they have to decide if they'll continue using that certain treatment or they'll go to a different one. And so these are usually used when normal medications such as like ibuprofen and Tylenol no longer cut it for the pain. And so next I have a disorder, and this is glenohumeral joint instability. And this is a very common shoulder disorder, and repetitive motions or frequent dislocations as a child. And then as you progress through adolescence and adulthood, it kind of gets a little worse as you get older. And so because of the shoulder joint, it's such a mobile part of the body. What it has in mobility, it really lacks in overall stability. And so due to this lack of stability, frequent abnormal motions of the shoulder and the arm can cause locations to occur very easily and more frequently. And then this instability disorder can occur as a result of that. And so when frequent dislocations occur within the shoulder joint, both the labrum, which we talked about a little earlier, and it's that soft fibrocartilage in the socket cavity, and then as well as the joint capsule, which completely encapsulates the joint, have to tear, and then that causes more mobility. However, in this case, more mobility is not a good thing. And then other fibrous tissues that help attach your bone and shoulder can stretch and tear as well. So those ligaments and tendons that we talked about have a pretty high probability of tear, causes more mobility as well. So and some patients complain of like a loose shoulder, and that's because the articular capsule and some different tendons stretch and tear during dislocation. And then symptoms can usually worsen with specific arm movements, such as carrying heavy objects or carrying things overhead, as well as certain sports with a lot of repetitive movements, such as like baseball with the repetitive movement of hitting the bat or catching a ball, as well as like swimming with the constant rotation in the water of moving your arms. That can also cause these symptoms to worsen. Treatments for this particular disorder can include different forms of bracing, which can serve as a form of stabilization for the shoulder joint, which decreases the hypermobility associated with this disorder, as well as bracing can also be used as a supplementation for surgery if that's the route a patient decides to go for this. And then another form of treatment is physical therapy. And the goal of the physical therapy would be to decrease joints instability pain, as well as return the joint to proper range of motion, and then also regain overall strength that may have been lost due to this disorder. And then finally, surgery is kind of like a last resort option in this case, and it's performed arthroscopically. And then during the surgery, the ligaments of the shoulder joint are reattached to the shoulder joint. And this helps tighten the shoulder socket back up and keeps it in place, and then improves overall shoulder laxity as well. And so this is just like a little hands-on activity, and it's basically a website that helps you learn the different locations of structures of the glenohumeral joint. I guess I can just show you quick. And when I was looking at it, it's all free from what I saw, and it actually can show you different regions of the body as well. So basically it's just a little game that helps you test your knowledge on the different structures within the glenohumeral joint. And that's all I've got.
Can you show us the game?
Oh yeah, let me get back to that. Give me 1 second.
I was writing down the website.
Oh, I can send it to you too. I'm sorry, I didn't even think about that.
Oh, that's okay.
I gotta get screen savvy. Here we go. So there's really, like, in this particular game, there's just 5 different things, but it'll tell you the ligament you're supposed to be looking for, and then you can attach it, or, you know, then you obviously, geez, I can remember it right now. There we go. And then you just connect it with the different one here. So let's see. Yeah, just like this. So it's pretty simple, straightforward.
And so do they have them for like each joint and stuff, or you can
So
like?
I was looking and it looked like they did when I was looking earlier. Oh, this is obviously not where I was looking. I have to remember where I was. And you can also like create a quiz, as you guys can see here, and like a leaderboard. But when I was looking, I did find a couple other ones, but now I don't remember how I got there. So I can try and see. But I can also send you or email you this link, and then you can put it up if that's what you want me to do.
Yeah, yeah. If you could email it to me, and then I'll post it, and I can play around with it too and see what else I can find in there. So.
Okay, yeah, sounds good. I'll do that right now before
Cool.
I forget.
Awesome. All right. So let me get something pulled up first. Let's see. All right. So let's talk more about the shoulder joint. As Sia told us, it is a ball and socket joint. So let's start by kind of reviewing some of the, well, all of the actions of the shoulder. And then we'll take a look at what muscles are involved in each of those actions. All right. So first thing I want you to show me is shoulder flexion. Show me shoulder flexion. Can you hear me? Can you guys hear me okay? Yeah, Val. Yep, shoulder flexion, straight out in front, okay? Shoulder extension, back to our side. Shoulder hyperextension, reach back behind you like you're gonna get a baton and track, okay? So flexion, extension, hyperextension. What plane of motion am I working in?
Sagittal.
Yes, correct. Okay. Show me abduction. Shoulder abduction. Yep, abduction away from the midline. Show me adduction. Come back to center. Okay, what plane of motion here?
Frontal.
Frontal. Good. Okay, show me internal rotation. Shoulder internal rotation. So there's kind of like, I don't know, I think of it like two different ways to show this. So one is if I have my hands kind of by my side, internal rotation, my hands come in. External rotation, my hands are out. Okay, you can also do that from this position as well. Okay, so external rotation is here. This is also external rotation. Internal rotation is flipped down. Okay, so external, internal, or also internal, external. Okay, again, if you see something that's medial and lateral rotation, that's the same thing. Okay, so medial rotation, lateral rotation. Okay, so those terms are used interchangeably. What plane of motion for those two actions?
Transverse.
Transverse, very good. Okay, and then the last two motions that we can do in the shoulder, show me horizontal adduction, a dreamy date. Yep. So horizontal adduction, a dreamy date, we're gonna give them a hug, okay? Horizontal abduction, a bad date. Yep, get them away. Okay, what plane of motion here?
Transverse.
Yep, transverse. Okay, so again, when we think about ranking the joints of the body, the shoulder is the most mobile. It has the most options available for different movements, even more so than the hip because of the bony arrangement that we see within the shoulder allows us to have greater range of motion, and that's okay. So we're going to give up stability when we have greater range of motion, but that's okay because we're not carrying as much weight usually with our shoulders as what we do with our hips. So our hips are will give up range of motion in replacement for stability. So we want to have a great amount of stability in our hips because we need to use them to like walk around and shit like that. So it's important that we have greater stability and less range of motion with our hips. So I'm going to go through, if I can share my screen here, the muscles of the glenohumeral joint. Why is this coming up? You can see it? Yeah, okay. All right, so I'm gonna skip over these. The only, I guess, bony landmarks to kind of hit on when we think about the humerus is greater tubercle, lesser tubercle, inner tubercular groove, and deltoid tuberosity. So let me grab a model here. Okay, so first thing I want to do is figure out which humerus I'm working with. And I can do that by understanding where the radius and ulna are. So again, once I kind of get myself oriented here, I can tell that this is a left humerus. And I can do that by looking at what's going on here at the most proximal spot. So I have the greater tubercle is going to be more lateral, the lesser tubercle is medial, and then the inner tubercular groove is like this little trough that's lying between these two bumps. Okay, so again, greater tubercle is lateral, lesser tubercle is more medial, inner tubercular groove lies in between them. Deltoid tuberosity, I'm going to have you guys palpate this on yourselves, because it says tuberosity, which is supposed to mean bump, but it's not really like a definitive bump in reality on your arm. So the easiest way to find this on yourself, I want you to go to abduction and palpate your deltoid, which is this muscle here on top. And again, delta means triangle. So if I kind of follow the edge of my deltoid down to the bottom, I can feel where it kind of converges. And it's about midway, I would say, down my humerus. But anyway, that's where it's going to have its insertion point, is on that deltoid tuberosity. Okay, so if you see an image on like an exam, for example, that might be coming up of a humerus and it's pointing to a bony landmark that's like in the middle of the humerus, it's probably got to be the deltoid tuberosity, right? Because these three are going to be more proximal, and deltoid tuberosity is kind of like in the middle of the bone. Yeah, you can take a look at that as well. Again, that's just kind of reviewing the different bony landmarks associated with the shoulder joint itself. Again, here you can see probably a better image than me trying to show you the bone. You can see that greater tubercle here, the intertubercular groove, and then the lesser tubercle. Again, to kind of orient yourself from anatomical position, the greater tubercle is lateral. The lesser is more medial in nature. That deltoid tuberosity is kind of like right in the middle of the humerus. We'll get to these bony landmarks when we talk about the elbow, which I think is on Monday. Okay. Again, we covered the movements of the shoulder, but again, repetition is key to memorization. So flexion and extension occur in which plane? Val, you're muted. I know you tried to say something.
Sagittal.
Sagittal, abduction, adduction, which plane?
Frontal.
Frontal, and then rotations?
Transverse.
Transverse, horizontal, abduction, adduction?
Transverse.
Transverse, very good. This just shows you, you know, some of those different images. Again, we kind of talked about the difference between internal rotation and external rotation depending on that shoulder position. Again, you're activating really the same muscles regardless of whether your elbow is up or whether your elbow is down. It really has to do with where the force is coming from in regards to which muscles we might be activating. Okay. So I kind of broke up the muscles into 3 sections. So we have anterior muscles, 3 of them, superior muscles 2, and then the posterior muscles 4 here. I have the rotator cuff muscles kind of interspersed amongst these, and we'll talk about those. Again, I think we had 6 muscles on the shoulder girdle. A lot of people get those joints confused, all right? So try to keep those separate when you're thinking about motion. Again, remember, if I ask you something about shoulder joint or glenohumeral joint movements, it's got to be one of these muscles. If I'm asking about shoulder girdle muscles, remember that's trapezius, that's rhomboid, that's pec minor, that's serratus anterior. So again, try to keep those kind of in their own little compartments, and hopefully that will help you on some of those quizzes and exams, just kind of based on those context clues. Okay, so let's take a look at each of these muscles. Pec major will be our first. It's radiate muscle. So again, if you remember back to the muscle fundamentals, it's got a wide origin, and then things are going to kind of converge down to have a common insertion point. Again, this allows us to have a great amount of stability and produce a decent amount of force. Check out all the different things we can do with this muscle. We can do adduction, internal rotation, flexion, horizontal adduction, and extension. That's a lot of things. We are going to insert on the lateral side of the humerus here on that greater tubercle of the humerus. But again, the reason we can do so many different things is because of the variety of fiber arrangement that you can see here. So again, these lower fibers are kind of running this direction, the middle fibers are running kind of straight across, and then your upper fibers are running kind of almost perpendicular to what we see in those lower fibers. So let's take a look at how that might affect the joint action themselves. This one I can like demo on myself, so I'm kind of excited about it, right? So again, imagine that the point of origin is on your sternum here, and I'm coming across this way, okay? So what actions do you think these middle fibers can do in order to shorten? It's much easier when I have like somebody as an example to do these. Actually, could I do him on my skeleton? I think so. Let's take a look at him. Can you see him? All right, so what things would, and this is not the good, the shoulder's not movable. This one is though. I'm getting too complicated here. What things can these middle fibers do? What are they going to be good at? How are they going to shorten this band?
Internal rotation.
Okay, so internal rotation, absolutely. So I need like one more hand to help me with this. So as we rotate, again, you can kind of visualize that that band is going to shorten as we do so. Yeah, kind of. Okay, so internal rotation, yes, absolutely. Okay, one other thing that these middle fibers are going to be really good at. I guess the other way to think about this is people that are athletes or exercise, which is quite a few of you on this Zoom call right now. What do you do to strengthen your pec major?
Push-ups.
Okay,
Or-
push-ups. Yeah. So what action is push-ups?
Deduction? Deduction?
What action is the pushing up part of a push-up?
abduction. Or like that'd be
Is that the horizontal adduction?
Yes, horizontal adduction. Yes, exactly. So again, if that's easier to think about that way, then think about it that way, right? So horizontal adduction, that's what we're doing when we do a push-up or bench press. And if you know that that's going to strengthen this muscle, then, you know, use your deductive thinking to put those things together. So again, those middle fibers are going to be really important for horizontal adduction. So those are going to easily shorten as we kind of push forward. Okay. Adduction. So again, bringing my arm back down, that'll be kind of those lower fibers. So those will be involved there. When we think about flexion, again, probably these upper fibers will be involved with that. Again, the kind of the point with this is there's a lot of ways that I can activate this muscle, which means there's probably a lot of things I could do to strengthen this muscle or injure this muscle or stretch this muscle, okay? So when we think about the application of this as it relates to physical therapy or rehab or strength and conditioning, right? It's really important that we understand all the different roles that this muscle might play so that we can figure out how to stretch it, how to strengthen it, how to rehab it, you know, depending on, you know, what the scenario is. Coracobrachialis, this muscle is kind of like just a dinky little guy. Tells you where it's located based on its name. So coraco has its origin on the coracoid process of the scapula. So again, that little anterior projection here. And then it's going to just be a straight muscle that's just going to go straight on down to the middle shaft of the humerus. Again, it's not a big muscle, so it's not really playing a large role in any of the actions, but it will assist with flexion and also adduction of the humerus or of the shoulder joint. Deltoid, this one's a nice one. So delta means triangle. So again, the shape of the deltoid is triangular in nature. The origin is very broad. Okay, so the origin again is broad, which tells us that it's going to allow us to generate a pretty good amount of force. And then it's going to converge together to form a common insertion point on that deltoid tuberosity of the humerus. Okay, one thing I would recommend, the deltoid does almost everything that can happen in the shoulder. The only thing that the deltoid cannot do is adduction. Okay, so if there's a question on the shoulder joint and it's like list, you know, 3 muscles that can do X, Y, Z, and you're not sure, I would definitely guess deltoid, because deltoid can do everything in the shoulder except for adduction. Okay, so I think I should be able to demo what's going on with these. Let's see. So I gotta move back over here. You just see my belly. Okay, so again, when we think about this radiate arrangement, there's kind of 3 different types of fibers. So I have the middle fibers, which are going to run straight over the top. I have anterior fibers, which are going to kind of run on the front side. And then I've got posterior fibers, which are going to kind of run on the back side. Okay. So those fibers that lay right on the top of my shoulder are going to be my strong abductors. Okay. So they're going to allow me to get to abduction. They're very good at that. Okay. Flexion, again, if I move to the anterior side here, they're going to assist with flexion. Okay. The posterior side is going to assist with extension. Medial and lateral rotation, again, depends on which side you're on. And then that horizontal adduction, the anterior side, will help with that. Horizontal abduction, the posterior side will help with that. Okay. The posterior deltoid is the only muscle in the shoulder joint that helps with horizontal abduction. Okay. Can you think of a strengthening exercise that you might do for that action? For horizontal abduction, a bad date. Can you think of anything to strengthen that? Again, we said horizontal adduction would be strengthened by push-up. So think of something that would maybe be like the opposite of that.
Maybe like a plank. Could a plank do that?
A plank will use it as kind of a stabilizer for sure. But I think really what we're trying to do when we do a plank is activate our core, but it's definitely involved for stabilization. Yeah. Anything else you can think of that does horizontal abduction as kind of like its main action in the weight room or?
She's frozen on your guys' screen too.
Yeah.
Can you hear me? Am I back?
Now we can. You kind of like froze for like a little bit.
So does that mean you guys know the answer then?
No, we like did.
You didn't hear the question?
Yeah.
What exercise could I do to strengthen horizontal abduction? Oops. Okay, so again, think about this. If I do a push-up to strengthen this side or horizontal adduction, I got to do something opposite with force in order to activate the other side. Okay, what could I do that's going to do this motion with requiring me to produce force?
I don't know what it's called, but like those bands that you connect like a pole and then you like pull them back.
Say it again.
So like, you know, when you connect like a band to like a pole or something and you pull it back.
Yes.
I don't know what that's called, but
Yes, absolutely. Like a high pull.
yeah.
You would call that. So again, you have like a band and you're doing something like that. Absolutely. Yep, that's one example. Can you think of one more?
Is it like bench press?
Bench press would do the same as a push-up. So that's going to be more focused on that anterior side, on that horizontal adduction piece.
Would a pull-up work?
Pull-up would be kind of, yeah, ish. It would. I can't wait to have you guys in strength and conditioning. I'm excited now. How about like a bent over row of some sort? Okay, so I could do something like this, or I could do like a reverse fly. That would be a really good way to do that. So if I do a reverse fly, the only thing I'm activating in the shoulder joint is that posterior portion of the deltoid, because that's the only muscle involved, right? You're going to have lots of other muscles at other joints that are helping with that. But again, if you've ever done this exercise, Like you can't do that much weight, especially compared to like how much you could bench press, for example. So think about those differences when we think about force production. Well, there's not a whole lot of muscle there that can help with that action. So therefore, you know, I can only do 5 pounds or whatever with that. Whereas with bench press, maybe I can do 100, right? So again, think about those differences and try and make those kind of connections if that's something that helps you. Supraspinatus, the first of our rotator cuff muscles. It's located in the supraspinous fossa of the scapula, and its job is also abduction. So supraspinatus is going to actually do the first 30 degrees of abduction. Okay, so if I start here, supraspinatus gets me to about here, and then deltoid will take over the rest of the way. Okay, so supraspinatus, first 30 degrees of abduction, and then deltoid will take over as the primary mover from the rest of the way. Lats. So this is sometimes called the swimmer muscle. And it's because when I swim, I'm able to activate all 3 of these actions at the same time. Look at the broad origin for this muscle, right? Huge origin tells us that it's very good at generating a great amount of force because it's such a stable muscle. It converges together to have its insertion on the intertubercular groove of the humerus. It kind of like wraps around too. So it'll kind of like come around to the inside and insert kind of on the inside of your arm, if that makes sense. Okay, and that's what allows it to do that internal rotation piece. Okay, so let me show you what I mean by swimmer muscle. Okay, any swimmers out there? No? I can show you some technique things then. All right, so again, called the swimmer muscle because when I do freestyle, I'm able to activate all 3 pieces of these actions. Okay, so freestyle is like this one. Okay, so again, when I do freestyle, the main motion, I need to extend. So I'm pushing the water with my hand here. I also am going to like come towards my midline. Okay, so I'm going to come towards my midline. My hand is almost going to touch like my belly button. So that's the adduction piece. And then as I start to exit the water, I'm going to do some internal rotation as I kind of flick my hand back out. Okay, so extension, adduction, and internal rotation will allow me to get a great amount of force as I swim. Okay. So again, if that's helpful for you, if that little tip is helpful, great. If not, you're like, I don't know a damn thing about swimming, then forget it. But for some people, it might be helpful. Okay. Teres major is known as the lat's little helper. It does the 3 same exact activities. So it also helps with swimming. So extension, adduction, and internal rotation. Notice that it's located here kind of on the bottom border of the scapula or on the inferior angle of the scapula. Teres minor is slightly superior to teres major. Okay, so teres major attached here, and teres minor is slightly superior here. And it does one of those actions, so it will help with adduction, but also does external rotation. So it's an opposite to teres major. So teres major did internal rotation, teres minor does external rotation. Again, this is rotator cuff muscle number 2, and we'll talk about what that means here in just a couple minutes. Infraspinatus, same exact actions as what we saw with teres minor, okay? So its origin is the infraspinous fossa of the scapula, also does adduction and external rotation. So same things as what we saw. Can you guys still hear me? Or did I freeze? Can you hear me? Yeah. Okay, sorry, it said my internet was unstable. So again, infraspinatus and teres minor do the same exact things. And infraspinatus is also a rotator cuff muscle. Sorry, forgot that. Okay, subscapularis. This one's kind of weird. So imagine that there's a muscle that lies, it's like a sandwich of here's my scapula, here's the muscle, and then here's the back of my ribs, if that makes sense. So it's like hidden. It's like hidden underneath there, if that makes sense. So I could never really actually touch it because it lies underneath this bone, but in front of my ribs, if that makes sense, okay? Its only job is internal rotation. Again, super important for stability of that shoulder joint, as it is one of those rotator cuff muscles as well. Again, as I mentioned, rotator cuff muscles, there are 4 of them. Supraspinatus, which we said does the first 30 degrees of abduction. Infraspinatus, teres minor are going to do the same 2 things. So they're going to do external rotation and adduction. And then the subscapularis, which we said was like that weird anterior muscle that lies on the anterior side of the scapula, and that'll help with internal rotation. Okay. One trick, I guess, to remember these is sits. Let's see if I use a black marker, if you're able to see these. Can you see that? Trying to play things out here. So supraspinatus, infraspinatus, teres. It's teres minor, not teres major. Okay. What did I miss? Subscapularis. Hard to kind of keep these straight as it relates to joint actions. Again, you'll be able to have your notes when you take your exams and stuff. But one thing that I don't know why this helped me, but it's always helped me, is I remember it does external rotation. Okay, so infraspinatus, teres minor do external rotation. Again, I don't know if that's helpful for you or not, but for some reason that like little saying like helped me in my life. So any questions on any of those muscles? Everybody's okay. All right. I did not grade the shoulder girdle lab yet. I'll do that today. Tell me how the movement analysis stuff went. Was that okay? Do you guys want to go over that? You want to wait until I see you next time and have those graded to go over those? What do you think? I know those are hard. Are you feeling okay on those? You want me to grade them and then we'll talk about it, or what do you think? Luis is saying yes. Okay. No comment. All right, let's look at today's lab homework. Oh shit, I gotta go back and share it with you. I forgot. Here we go. Okay, first part, no problem. You can figure that out from what we went over today. Okay, again, in this chart, also, I think pretty self-explanatory. Just list all the muscles that can do abduction and then what's the plane of motion. Okay, so again, that should be just another kind of way to be repetitive with your muscles. Okay, what's an agonist versus antagonist? Remind me.
The agonist is like the main muscle mover, and then the antagonist like is the opposing muscle. Like.
Yep. So the antagonist does basically the opposite. Now the tricky part with like the shoulder joint, for example, is like we said, the deltoid does horizontal abduction and adduction. So it does both actions. So it's its own antagonist. I know that's like super confusing, but that happens in this particular area. So what I would try to do when I would do this chart would be like, okay, agonist, deltoid. Okay, what's the major movement of this muscle? Like, what's the most important thing it can do? That's probably abduction. Okay, so I would try to list an antagonist that does the opposite. What does adduction? Okay, so again, you can list one thing here. Again, if I'm going to choose an antagonist for abduction, we said was deltoid. Adduction, what's the strongest adductor that we have? I would say it's latissimus dorsi. It's the largest of the muscles that could help with that. Again, there's kind of like 3 different muscles that do that action, but try to choose the largest one. If you want to list all 3, that's great. Okay, that's no problem. I won't mark you off for that or anything else. Okay, so that's what I'm kind of looking for there. Again, when you go down to this movement analysis stuff, this is the hard part, I think. You want to do one together again? Yes? Okay, which one you want to do? You want to do push-up, pull-up, or dip? Do you know what each of these are? That's the other thing. Maybe everyone in this group does, but maybe I should talk about them just in case other people don't, okay? So again, I think a push-up is pretty self-explanatory. When we talk about a wide grip pull-up, okay, my hands are out wide and I'm gonna lift myself up like that and then let myself back down. So I'm like hanging from a bar. So the main thing to think about with this is that my hands are out wide and I pull myself up and then lower myself back down, okay? When I'm talking about a dip, I'm talking about like a tricep dip. Let's see. Okay. So with the tricep dip, I have my hands kind of on the edge of some sort of surface and I'm lowering myself down and I'm pushing myself back up. Okay, so just going down and back up. So again, there's lots of different things going on in all 3 of these activities. It's just focus on only what's going on at the shoulder joint, okay? So which one do you want to do? You tell me which one.
Dip.
Let's do the dip. Okay. So again, let's think about what the joint action is. Again, first thing we need to do is think about the lifting versus the lowering phase. So if I'm in this position to start with, what's my joint position? Like what's my shoulder doing right now?
Extension.
Tension.
Extension. Yep. So when I lower myself down, what position is my shoulder in?
Hyperextension.
Hyperextension. Yep. So that's the lowering phase is hyperextension. And then as I lift myself up to get back to extension, what's the action? So to get from here to here, what did I have to do? I'm out of breath. I did 1. I did 2. Let's give me that. Okay, so I started here, okay? I did hyperextension on my lowering phase. And now I'm bringing myself back up.
Flexion.
Yep, flexion, okay? So I have to do some flexion to get myself back to that original position, okay? So my lifting phase is flexion. My lowering phase would be hyperextension, okay? The next thing we want to think about is what's the hard part of that exercise? Is it lowering yourself down or is it lifting you up?
Lifting you up.
Yeah, the lifting phase is hard. Okay, so the lifting phase, right here, you want to also put concentric contraction. And if we know that we are shortening on the way up, that tells us that we must be doing what on the way down?
Eccentric.
Correct. Okay, so you've got concentric here for dips on the lifting. and eccentric here on the lowering phase. Okay. So now the next thing we need to do is figure out, okay, if I'm doing flexion concentrically, what muscles are going to be involved in that? And really two major players here. What two shoulder muscles are going to help with flexion? Who's the one I said can do pretty much everything? This is a superstar of the shoulder.
Deltoid.
Deltoid is one, absolutely. Okay. And then one other muscle involved in shoulder flexion. Well, one other big muscle, I should say. I know you don't have any notes yet to look back on. Well, have you done dips before? And besides your triceps, where else do you feel it?
Chest.
Yes. What muscle then?
Pectoralis major.
That's correct. Yes. So deltoid and pec major are going to shorten here. So that tells us that those same muscles have to lengthen here. Okay. So deltoid, pec major, and deltoid, pec major. Okay. So lifting phase, flexion, concentric, deltoid, pec major, lowering phase, hyperextension, eccentric, pec major, deltoid. Questions on that? Everybody's okay? Okay, I think the rest of that is pretty self-explanatory. Let's talk about, just real quickly, any questions on, I don't even know what day it is. What's today? Wednesday, the 3rd. Any questions on integumentary system that you went over yesterday? That lecture, everybody's okay there. Lectures are doing okay. All right. Questions about the exam on Friday. You have your first exam on the lecture material. Again, the lecture exam will be exclusively lecture material. There'll be nothing from the lab on there. Okay. Questions on any of that?
How many questions are there?
There's 75 questions, and I believe I gave you 75 minutes. So each question is, they're all multiple choice. Each question will be worth 2 points. I was thinking of, I know I have it listed as lecture exam 8:30 to 9:30 a.m. What if we do, I'll open it at 8. So it'll be open from 8 until 10 a.m. And then we'll have the review for our lab session at 10 a.m. Does that sound okay to people on Friday? Okay. Okay. Any questions on anything else for exam for Friday?
Well, we have to know what the sacromere is.
Say that again.
Well, we have to know what the sacromere is.
The sarcomere?
The sacromere, yeah.
Yeah, I would think so. I mean, that was part of the muscular system. Yeah.
Mm. Can we go over that?
The sarcomere?
Yeah.
Sure. I wonder, I don't know how to do how to make the whiteboard. Does anybody know how to do that?
You like click. I've done it before.
I suppose I could use like the actual whiteboard too, huh? It's a little hard for you guys to see that though, but I'll do my best. So the sarcomere is like the basic unit for muscle contraction. So again, it really contains two things. It has myosin and actin, and myosin and actin need to interact in order for contractions to occur, okay? Which one's thick and which one's thin?
Actin is thin.
Correct. So actin is thin, myosin is thick. Okay, so in order for the muscle to shorten for concentric contractions, these two guys have to interact, and basically what I want to do in order for that to occur is the actin is going to slide together until it runs into each other. Okay, so myosin pretty much stays stable and actin is going to like slide in and run into each other, if that makes sense. Okay, the way in which that happens is myosin has like these little, I don't know, but think of like a little head. It's like a little ratchet thing. So it's like a little strap with a little something on the edge that can grab a hold of. Okay, so this myosin head will attach onto actin and pull that actin towards the center. Okay. And that'll continue to happen until these guys run into each other, and that's when we've reached like a full contraction. Okay, so again, think about it like this way. Like if I contract my bicep, for example, well, I can't shorten any further than this because the actin is running into each other at that point. Okay, so there's a limit to how much I can contract based on when these guys start butting up next to each other. So basically, when we think about what's the sarcomere is just this unit, what's going on within this unit. And then, of course, you know you have troponin and tropomyosin that's located on the actin molecule as well, and that'll play a role in this whole contraction process. Yes, right?
Okay.
More or less, that was good?
That was good.
Okay. So within like one single muscle, we have like thousands of these. So thousands of these, imagine them kind of like Legos. Like they're all kind of stacked up next to each other. And so in order for us to have like that full muscle contraction, I'm going to have all of these myosins of every single like Lego piece, basically, contracting at the same time in order for that shortening mechanism to occur. So sarcomere is just simply like the basic unit for muscle contraction, which seems like super arbitrary, I guess, but nobody asked me my opinion. So any other questions, you guys, on anything that we've covered so far for lecture, or everybody's doing okay? Okay, and then I'll talk about the lab exam in more detail. I'm going to finish writing it today, and then I'll talk about that in more detail on Friday when we meet. All right. So again, that exam will be open from 8 till 10 on Friday, and then right at 10, we'll do our review session for the lab. You'll have 75 minutes to take that exam. It's all multiple choice. All right. If you do have questions while you're preparing, or, you know, going over the lectures and your handouts and that sort of thing, just let me know, email me or whatever. So, all right.
Okay.
I think that's all I have for you. I think so. Let me check my notes. Yep. That's all I got. So have a great day. And like I said, just let me know if you have any questions as you're working on this stuff. Now you're all frozen. Oh, can you hear me? Okay.
Oh, we can.
Okay. Have a great day. That's it.
You too. Thank you.
Yeah.
Bye.
Thank you. Bye.